Thank you, ma'am, for your kind words. So today I'll be speaking on a clinicopathological approach. To start with, kidney organ. As it has a number of compartments, the glomerulus, the tubules, the interstitium, and the blood vessels, and each compartment has a story to tell. So every compartment has a story to tell, and different compartment involvement leads to different clinical manifestations. So it is basically our clinicians who are making the diagnosis at the bed, along with a number of investigations. So how do we actually go about making a diagnosis? As I discussed, there are a number of syndromes which are associated with the different compartments. We have the glomerular syndromes. We have patients presenting with isolated hematuria. Then the tubulointerstitial compartment, if that gets affected, the patient lands up in acute kidney injury and presents with acute kidney injury and another syndrome, that is tubulointerstitial nephritis. Vascular pathologies as a result of benign and malignant hypertension, and a major chunk of diseases, that is chronic kidney disease. But majority of the biopsies that come to us, they are around 70 to 80% of the times the indications are nephrotic. The patient in nephrotic and nephritic syndrome, presenting with rapidly progressive renal failure or isolated hematuриas. So I would be concentrating mainly on these syndromes, as most of us are aware that nephrotic syndrome will present with the child or a patient of nephrotic syndrome will present with massive proteinuria of the range of more than 3 to 3.5 grams per day. In a child, the cutoff is a little reduced, that is, it's more than 1 gram per meter square per day. The following proteinuria, there will be hypoalbuminemia. The patient will land up in anasarca, and there will be hyperlipidemia and hypercoagulability. The urine sediments here in a case of nephrotic syndrome are bland, meaning thereby there are no RBCs in the urine sediment of this patient. The other syndrome, that is nephritic syndrome, the patient will present with subnephrotic range proteinuria, that is 2 to 3.5 grams per day of proteinuria in a day, along with azotemia, that is, there is retention of the blood urea nitrogen and serum creatinine, and there will be a hypertension component as well. The patient will also have oliguria, so it is an emergency. To treat people with nephritic syndrome, it is a little more critical than a very insidious onset nephrotic syndrome. And the urine sediments in this patient will be active, meaning thereby there will be microscopic hematuria or gross hematuria. That is more than 5 RBCs per hyperfeed, along with the presence of RBC casts. The other syndrome is rapidly progressive renal failure, wherein there is doubling of serum creatinine in a matter of hours or days. So it is an acute crisis for the clinician to handle such patients. And as mentioned earlier, that these the urine sediments in this patient will have a number of dysmorphic RBCs and RBC casts. So to starting with the investigations, the basic investigations, we have the dipstick test, which has replaced the conventional tests, the urine test for protein and sugar and other this thing. So the dipstick test for urine, it has replaced, but what has to be kept in mind is that the protein test, the dipstick test for protein, it actually measures albumin. So if we have proteinuria, which is due to the other proteins coming out, if we have proteinuria which does not have albumin component, it will be missed because the dipstick test is sensitive for albumin. And we have a range of color changing from yellow to green. The other important thing that has to be kept in mind while reading the dipsticks are that the blood component. We can see this, that the dipstick test for blood, it can give you false positive tests with free hemoglobin or free myoglobin. So whenever clinicians are asking for the test through dipstick for blood, they always should go for confirmation with microscopy, because free hemoglobin as a result of hemolytic anemia or free myoglobin, they can give a false positive test on the dipstick, and that has to be taken utmost care That has to be taken at least care. We consider hematuria to be of glomerular origin, like in a number of nephritis, glomerulonephritis, post-infectious glomerulonephritis, membranoproliferative glomerulonephritis. We consider hematuria to be of glomerular origin only when the RBCs appear to be dysmorphic. Dysmorphic means they are RBCs of different morphologies. We can see here we have some different shapes and sizes of RBCs. Here we have some blebbing on the surface of the RBCs like the ears of Mickey Mouse. So these are dysmorphic RBCs, and the cutoff for this is more than 40%. Only then we consider the hematuria to be of glomerular origin. In case it is from the other, like if it is due to bladder disorder, bladder stones or anything, the RBCs here will be isomorphic, of same morphology, similar size and shape. Now, urine sediment examination in the diagnosis and management of kidney diseases is important, especially for pathologists, because here the urine sediments are telling you which compartment is involved. And this is especially for our pathology residents. We have certain clues that the sediments give us. For example, if you have the brown casts, muddy brown granular cast, this brown color, that will tell you that it is coming from the tubules. It is coming from some injury in the tubules, acute tubular injury. Then we have different colors of the casts, and they tell you which compartment is involved in the kidney. We have the waxy cast, we have this lipid cast, which you get in nephrotic syndrome, the WBC casts, which you can get in glomerulonephritis, you can even get in interstitial nephritis. These are the renal tubular epithelial cell casts. You should always go on a higher part to look for the constituent of the casts, and they tell you from where they are coming. Now, another important laboratory test is the 24-hour urinary quantification for protein. And this test has largely been replaced by the spot urine protein to creatinine ratio. Why? Because for a 24-hour urine collection, that's a very cumbersome procedure. We need to collect sample for 24 hours. We ask the patient to collect the urine specimen in a big container from 8 a.m. on the first day to 8 a.m. on the next day. So that's a very cumbersome procedure that has largely been replaced by the spot ratios, the spot protein to creatinine ratios. And the good thing is that these spot ratios very much correlate with the 24-hour urinary protein. For example, protein creatinine ratio of 3 is diagnostic of nephrotic range proteinuria, and it corresponds very well to the 24-hour urinary protein, that is more than 3.5 grams per 24 hours. And they are easy to obtain also. For example, in a child, 24-hour collection will be very cumbersome. So that is why these spot ratios are replace a 24-hour urinary protein collection. Now, just summarizing, the quantification of protein can tell you which syndrome the patient has landed up in. Normal urinary protein, the excretion will be less than 200 milligrams per day of protein with less than 20 milligrams of albumin. Microalbuminuria, we all know it's an indicator of early diabetic nephropathy and hypertensive nephropathy. The range is very much less. It's 30 to 300 milligrams per day, which cannot be picked up by the dipstick test. And then we have subnephrotic proteinuria, which is a proteinuria level of more than 2 grams per day is highly suggestive of glomerulonephritis, nephritic syndrome, where you have active sediments in the urine. And nephrotic range, we have already dealt with this. Now further on, just to add on to the list, we have these tests being ordered for evaluation of proteinuria. If you are suspecting diabetes, then blood glucose, glycosylated hemoglobin, the entire autoimmune panel for the various nephritic syndromes like anti-nuclear antibody, anti-neutrophilic cytoplasmic antibody, anti-GBM antibody, and the serum complement levels, which go down syndrome because there is a lot of inflammation and there is deposition of immune complexes. So the serum C3 levels will go down. A number of viral markers to determine the etiology of membranous or FSGS or MPG. So now all these tests, like when the biopsy comes to us, the renal biopsy comes to us, a diagnosis of nephrotic syndrome, nephritic syndrome, or rapidly progressive renal failure, that's already been made by our nephrologists. So what does a pathologist do then? In our college, in our department of pathology, we are carrying out light microscopic evaluation of renal biopsy along with immunofluorescence to render a diagnosis. And this is how the glomerulus looks like under the different stains. We have, this is the hematoxyl and eosin stain. This is the pars stain with the magenta colored basal membranes, the Mason's trichrome stain, and the silver methylamine stain. So we have to look at each compartment to determine which. So the renal biopsy evaluation, we have to carefully look at the 4 compartments. The glomerulus, this appears to be quite full and hypercellular. The tubules filled with a number of myoglobin casts. This patient had landed up in ATN, was oliguric, dialysis dependent, and 19-year-old male, and landed up in acute kidney injury. And when the biopsy came to us, there were a number of myoglobin casts in the tubules. They were vermiform, ropey, beaded casts in the tubules. And in this case also, the blood test in the dipstick was 3 to 4 plus. But under microscopic evaluation, there were hardly any RBCs. So it was because myoglobin was giving a false positive test for the blood, and there were no RBCs in the urine sediment. So although I have taken these pictures from the net, these are not pictures from our case, but we had a similar case. And then there can be some pathology in the interstitium as well. The patient might land in acute interstitial nephritis because of any drug exposure or because of any infection. So these are just a schematic diagram of what we the diagnosis of nephrotic syndrome already comes to us when a biopsy comes, but we have to further on determine whether it is due to membranous nephropathy, or it is because of minimal change disease, or focal segmental glomerulosclerosis, or any other cause. Now, along with the renal biopsies, we are also carrying out immunofluorescence. So what is the basic principle of fluorescence? It is it's a phenomena by which a substance that is a fluorochrome, this fluorochrome, it absorbs light energy and it very rapidly emits a part of it at a higher wavelength, at a longer wavelength. So these are the 2 different types of immunofluorescence. We are carrying out direct immunofluorescence in our department on the renal biopsies. What happens here is that we all somehow, which we remember from Robbins, that there used to be immune complex deposition in the glomerulus along the capillary basement membrane. So what happens is, this is the tissue, this is our renal biopsy, and there is some antigen antibody reaction that goes. There is some deposition of protein on there's some deposition of the immunoglobulins on the along the basement membrane or in the mesangium. These get deposited. Now what we do is that we take an antibody and we label it with a fluorochrome. In our case, it is FITC, which is fluorescein isothiocyanate. We label the antibody with a fluorochrome and we incubate the tissue with the antibody, which is labeled with fluorochrome. And then we have this IF microscope, which is specially designed to emit out light at a particular wavelength, and that blue light falls on the tissue, and the fluorochrome absorbs that blue light, emits light of green wavelength, which is larger than the blue wavelength. And that is why जो भी आप लोग IF images देखते हैं, that has green fluorescence being emitted. So this is what we are doing in our department. This is indirect immunofluorescence. The indication for this is for the detection of anti-nuclear antibody, for anti-nuclear cytoplasmic antibody in the serum of suspected patients. The mechanism is just a little one step more than what we had here. We have slides which are already coated with, they are already coated with monkey kidney tissue or rat liver tissue, normal monkey kidney or rat liver tissue. Now we incubate this with the serum of patient suspected of having anti-nuclear antibody or ANCA in the serum. After the incubation, if the patient serum has ANA, it will go and bind with the nucleus of the monkey kidney or the rat liver. In the second step, we are using the secondary antibody, which is labeled with fluorochrome. So it will go and attach itself to the primary antibody, and then it will emit out that similar fluorescence. So just one more step. Only if the patient serum has ANA, then will the secondary antibody go and attach itself. Other patient serum does not have ANA or ANCA, there will be no such reaction, no fluorescence. So these are the fluorescent images that we get. They are directed at identification of the pathogenic immunoglobulin and the complements. The antibodies that we are using are IgG, anti-IgG, anti-IgA, IgM, C3, C1q, and kappa and lambda light chains. And the diagnosis largely depends on what is the location of these antibodies, whether it is in the mesangium. If it is predominantly mesangium, predominantly IgA, the diagnosis changes, it becomes IgA nephropathy. And then if the antibodies, you can very well appreciate these rounded structures. These are along the capillary wall. So you have coarse granular deposits along the capillary walls. And here you can appreciate both. You have these along the capillary wall as well as in the mesangium. So the diagnosis, actually immunofluorescence is a game changer in many cases because these patterns, these are MPGN or mesangioproliferative, these are just patterns of injury. But based on the IF positivity, the diagnosis actually changes. And these are just the different patterns. We have coarse granular deposits. These are granular along the capillary wall. These are very fine granular deposits. And these again are band-like coarse granular deposits. To the interpretation of glomerular IF patterns, we can have different patterns. They can be granular in the mesangium, as I already said, IgA nephropathy. Then we have granular capillary wall. If it is finely granular, membranous, mostly granular, MPGN. And linear capillary wall deposits in a rare disease, usually not very commonly encountered, like anti-GBM disease. Now to sum up, I have two cases. This was a 48-year-old female who presented with a hemoglobin of 8.4 gram% and mild renal dysfunction with creatinine 1.63 milligram per dl. Serum calcium was raised, it was 11.5 milligrams per dl. Total protein here was 5.9 and the serum albumin was 2.5 gram per dl. So you can see the AG ratio appears to be reversed. The AG ratio is reversed because you have globulin. When we subtract protein minus albumin, the globulin appears to be more. Urine routine microscopy in this case was negative. And the 24-hour urinary protein here was 232 milligrams per day. So based on these, so the patient basically presented with anemia, renal dysfunction, hypercalcemia, and reversal of the AG ratio. So any guesses what the patient is, any suspicion, old age patient with these features? Yes. So a clinical suspicion of anyone? Residents? You have CRAB features. We have CRAB features of myeloma, hypercalcemia, renal dysfunction, anemia. Bony lytic lesion was not found. So a suspicion of myeloma was made. Workup for myeloma was done. Protein electrophoresis, normal. Serum free light chain ratio, normal. Bone marrow was done. It was sent to our department. Bone marrow revealed reactive plasmacytosis, 8 to 10 reactive plasma cells. No atypical plasma cells were seen. So a renal biopsy was performed. On evaluation, the glomerular compartment appeared to be normal. Tubules largely normal, but yes, we could see some calcification within the tubules. These are the intratubular calcification. Yes, but while going through the biopsy, there was a busy area here. There was a busy area in the interstitium, which appeared to be abnormal, not looking very normal. So the other thing was, on following the serial section, we could appreciate this fragmentation. First, I thought it was because it was not cut properly, but later on, see all the serial sections, it was seen that biopsy C area se specifically, it was very much fragmented, not coming pura in toto nahi aa rahi thi. There was a lot of fragmentation. So higher power view, I think the pathologist sitting here, we will be able to make out some slipper-shaped cells here, the small focus of slipper-shaped epithelioid histiocytes here, and then to confirm, we had a giant cell here. So a diagnosis of granulomatous interstitial nephritis was made. The patient was worked up. AFB, the section for AFB, it was fragmented. AFB section, maybe this entire piece of tissue had just gone off. So AFB could not be done. And the patient was put on ATT. The patient later on presented with fever, also was put on ATT. And now the patient is responding well. Another case of a 13-year-old female who had anasarca for 6 months. Her hemogram was normal. Serum creatinine was 0.6. milligrams per dl. Serum albumin was 2.6 grams per dl. 24-hour urinary protein was 1 gram per day. And the patient was treated with steroids. So do you think this is a nephrotic presentation? Urine analysis was normal. Urine analysis, active urinary sediments. Since she's a 13-year-old female, the cutoff for proteinuria nephrotic range is more than 1 gram per meter square per day. So this is nephrotic presentation in a 13-year-old female. And the patient was treated with steroids, but later on, after 6 months, she became non-responsive. So kidney biopsy was performed for non-responsive nephrotic syndrome. And we received 3 cores. All the compartments appeared absolutely unremarkable. The glomeruli also appear unremarkable. There is no mesangial cellularity. There is no crescent formation. There is no endocapillary formation, endocapillary proliferation, nothing. All the compartments appeared normal. So obviously we had a suspicion of minimal change disease, but then why was this patient not responding to steroids? That was the suspicion, and that was the concern of the clinician. So we had put immunofluorescence in this case. And what would you expect? What is the IF you expect in minimal change disease? We don't expect any immunoglobulin deposition or any complement deposition. So we expect a negative IF here. But what did we find? We found deposition of anti-immunoglobulin G and anti-C3 in this case. And rest of the IgA, IgM and C1q kappa lambda were negative. Kappa lambda was equal intensity, rest were negative. So absolutely a normal biopsy. We had a suspicion of minimal change disease, but IgG and C3 came out to be positive. So then the diagnosis was changed and we rendered a diagnosis of early membranous nephropathy. Early membranous nephropathy in the initial phases can look like an unremarkable. The glomerulus absolutely look unremarkable. You might not find any spikes, but the IF is a game changer in many of our biopsies, and this was given off as early membranous nephropathy. So that brings me to the end of this session, and towards the end, I would like to acknowledge a heartfelt gratitude to all the chairpersons and the audience for your patient listening. And also I would like very sincere thanks to my department of pathology, my teachers, Professor Mamta Singh ma'am, Vatsala Mishra ma'am, Kachnar ma'am, Vishal sir, and all my teachers who have taught me the ABC of pathology here. I joined in 2009 as MD first year. And later on, when I went to SDPGI, I was taught the basics of renal pathology there. So my sincere and heartfelt gratitude to my teachers. And of course, now we are doing immunofluorescence, and Pura department, our technicians, our residents, they are working really hard. Our residents actually put the immunofluorescence, and with the reporting, they run around here and there. बीच में कहीं IF भी लगाते हैं फिर सब. So a very sincere and heartfelt gratitude to all of you for your patient listening. Thank you.
Thank you, Dr. Varsha, for such a nice presentation. From a clinical clinician's point of view, I would like to explain why clinicopathological publication is so important for clinicians. In the case of in a nephrology case, we make diagnosis in 4 components. First being clinical part, clinical diagnosis or symptomatic diagnosis. Second being pathological part or pathological diagnosis. Third being etiological diagnosis. And the fourth depends upon the stage of the disease. If there is any staging that like in the So there are times when pathology information is not available to you, or it is not available in an emergency situation, because renal biopsy takes around 7 to 10 days to get the report. Earliest you will get a provisional report in 3 or 4 days, but usually it takes around 7 to 10 days. So there are situations where by this the knowledge of clinicopathological correlation helps you in suspecting pathology and starting the treatment as early as possible, especially in cases where there is emergency, like rapidly progressive bronchitis or rapidly progressive renal failure. Or there are cases where people are not ready for biopsy, or nephrologists will not do a biopsy because of bleeding disorder with the contract. So a knowledge of clinical pathological condition helps a doctor, a clinician, to suit empirical treatment, which may not be so empirical because he already knows that in this type of clinical picture, you are finding this type of pathology usually. You have read with the topic very nicely. Thank you, sir.
Thank you, sir. Thank you.
The topic is open to our discussion. Anybody has any questions?
Varsha, thank you so much. Really nice talk.
Thank you.
I have a very basic question. You have mentioned two what is actually your urine report, urine routine. That once the micros, the stick test usually measures and you can miss out on protein. So one is that. And the second is that RBC is very positive on the district and on microscopy you will be finding. So what do you propose as the reporting pattern in both these situations? Once you are not finding RBC, should your microdistinct test of RBC positivity be mentioned, or and the second one is that any albumin protein in the district, should you go in for a test for each and everything, or should you skip?
Okay. Ma'am, since our dipsticks are actually sensitive for albumin, albumin is a major component in our proteinuria. So most of the times it will be caught up. But if it is due to tubular proteinuria, where the clinician is suspecting, so in case where we can go for conventional techniques, or maybe myeloma case where we can go for a serum urine protein electrophoresis as well. Most of the times due to nephrotic or nephritic range proteinuria, these are detected by the dipsticks because albumin is the predominant component there. And tubular ke liye, they can go in for urine protein electrophoresis, or maybe they can specially mention that we want to get this test for especially to detect the globulin part, or for the myeloma proteins, we can carry out the conventional tests.
RBC absent in microscope,
Right.
and the myoglobin giving false positive. Should it be mentioned in the report, or should it be skipped?
It should be mentioned because the clinician is asking for RBCs in urine. We are giving a dipstick test, and that might give a false positive test with myoglobin and hemoglobin. That is what happened in this case also. This myoglobin cast nephropathy, the same thing happened. The same thing, when we saw the biopsy, it had those myoglobin casts. We reported the same, and we told whether a urine for myoglobin was done or not. तो फिर हमें पता चला कि dipstick पे it was positive 3 to 4 plus, but RBCs on microscopy. So it was retrospectively correlated. So we can always keep this in mind that अगर RBCs के लिए dipstick आ रहा है, which is 3 to 4 plus, but we are not seeing actual microscopy, we are not seeing RBCs, then we should have this in mind that the patient, uska sudden hemoglobin fall could be because of a hemolytic episode, or maybe because of some myoglobin. In mind. So in this case, it was a retrospective learning for us. But आगे से we can always keep this in mind कि अगर ये disparity आती है, so we should always inform the clinician regarding this, because this patient had landed up in anemia, dialysis dependent, later on resolved.
Excuse me, what is the clinical significance of urine protein, isolated urine protein showing traces in 1 plus protein? Clinical, how to evaluate these issues? Only isolated protein showing 1 plus reports showing protein traces in 1 plus also.
Right.
No,
Sir, that could be because of some physiological pregnancy. We have these cases of mild proteinuria, strenuous exercise, fever. तो वो तो glomerular syndromes की वजह से कभी भी नहीं होंगे. They'll always be 3 to 4 plus. We have mild proteinuria and some tubular UTI है, mild proteinuria. So they can be correlated there. These are usually mild proteinuria cases. So they can be followed up. Mild proteinuria, they can always be followed up because of fever, some strenuous exercise, these mild. So they should be followed up with a proper urine examination. Urine sediment में अगर कोई भी abnormality मिलती है sediment में, like granular cast and all, they should be sent to the nephrologist for a proper follow-up and workup.
Timing for the urine examination, because it has been conventionally first urine sample, either for the
We have always been, मतलब हम लोग हमेशा first morning urine sample, but there is a recent change. हम लोग first के बजाय now we are going in for the second sample because they say first urine sample में all the cells are lysed. तो आपको वो findings नहीं मिलेंगे. You go for a second urine sample क्योंकि जो first morning urine sample है वो overnight है sir. So the cells might get lysed, we might not get the proper findings. So second now is being recommended. The second urine sample now is being recommended for the evaluation, for proper evaluation.
So Gujrati sir, and you